Good morning, everyone. I see some waves. I think we might give it another minute or so for folks to log in and then get started.
Sarah, it looks like you're on mute.
Sorry, everybody. Good morning. I was just doing a lovely welcome for everyone and wanted to say thanks for joining us today. My name is Sarah Abelhart, and I am the SUD waiver policy analyst here at OHA and with the Medicaid Behavioral Health Policy and Planning team. So today we're just going to be doing a general overview of the SUD waiver and some overall projects and timelines and requirements that we're working on. We have some dedicated time on the agenda today from our licensing and certification folks, as well as our Medicaid counterparts. We're planning to leave 30 minutes at the end for a Q&A and any questions. So we're just kindly asking that you either hold those to the end or place them in the chat, and we'll be able to either address them at the end of the meeting or follow up later if a little bit more research or response is required. I'm also going to allow the OHA folks who will be presenting today a quick moment for introductions. So I will pass it over to Nicole.
Good morning, everyone. I know quite a few of you, so it's nice to see some faces I haven't seen for a while. I'm Nicole Corbin, and I am the Addiction Treatment, Recovery, and Prevention Services Manager here in the Office of Behavioral Health. And I will pass it to Sissy.
Good morning, everybody. I'm Sissy Bollinger. I'm the Manager for Licensing, Certification, and Technical Assistance. I'm so glad that all of you could make it. I will pass it to Melissa.
Good morning. Thanks for being here. I'm Melissa Farron. I work in the Licensing, Certification, and Technical Assistance Unit as a compliance specialist. And I will pass it to Dana.
All right, good morning, everyone. I am experiencing some technical difficulties with my camera, so forgive me for being a little bit rude and not showing my face on camera this morning. It's not on purpose, it's just for some technical difficulties, but I am the Substance Use Disorder Special Projects Coordinator with a focus on our medication-assisted grants. And I think, hopefully we have Delilah also logged in this morning, so I'll turn it over to her.
Good morning. My name is Delilah Morales, and I'm your Medicaid SUD policy analyst. And I apologize, I'm having technical difficulty. So I am on the phone. So Sarah, can you pass it to the next person? Because I can't see.
Sure. Actually, have we missed anybody who's presenting today? Okay.
This is Sissy. I just wanted to share. So I've already introduced myself.
Yeah.
I just wanted to share that Leticia Sains may be joining us late. She is our adult behavioral health director, and so if she pops in, we'll give her a few minutes. But other than that, we will just proceed. Thank you.
Great. Thank you, Sissy. I'm actually going to hand it back over to Nicole.
Thanks, Sarah. And do you have the PowerPoint presentation, if you want to put that up so that our participants here can take a look at that?
Sure, one moment.
So hello, everyone. And just to echo what Sissy said, Leticia Sains is our new Director of Adult Mental Health and Addiction Services. So she is deeply involved in this waiver and really is looking forward to meeting you all. She had a situation this morning that's caused her not to be here yet. So I know that she is looking forward to having a chance to meet everyone. So just wanted to echo that. And so I am sort of stand-in Leticia for the moment, but so hello, everyone. A lot of you who are here, I suspect, already know that we have been working on this SUD Medicaid waiver for, I believe it's 8 years at this point, through multiple different organization versions of back when we were AMH and now we are the Health Systems Division. I know that I see some names out there of folks who have been part of the substance use disorders thought leaders who have given feedback and ideas on what we really wanted to see in a Medicaid waiver for substance use disorder services. And so it's really exciting that we are at the point now where we actually get to start implementing this work after so many people have worked on it for so long. So I want to tie the substance use disorder Medicaid waiver, which we have been, as I mentioned, working on for a long time, into the larger direction where we are headed for our investments in behavioral health and for changing and improving our behavioral health system, right? I think that everyone knows that the Oregon Health Authority has a goal of eliminating health inequities by 2030, and that the hammering that our system and the people who work in our system and the people we serve in our system have taken during COVID has really highlighted and enhanced that commitment to eliminating inequities, because we have certainly seen that people who are essential workers, people who are Black and Brown, people who have substance use disorders have been disproportionately impacted by COVID. We've seen increase in substance use, we've seen increase in substance overdose. So all of that means that we are coming from a place that is even more in need than it always is. And I think that any of us who've worked in this field for any amount of time are aware that we have sort of always been in a place where the need is greater than the resource. So this is a pretty exciting time. It's a stressful time, right? I'm not minimizing that need. We get those calls every day, but this is an exciting time to have a chance to move forward because we are in a place where we have some investment and support from the legislature, right? There's a lot of funding that's going into behavioral health. We have support from the feds in the form of this CMS waiver. We have a opportunity to really change how people who have substance use disorders are interacting with the criminal justice system in a way that's more trauma informed in the wake of Measure 110 passing here in Oregon, and those investments that will be going out into the communities to create behavioral health resource networks. So we are at a moment right now where we are headed to knowing that we've got some big challenges, but we've got some incredibly talented and dedicated people, and we have some resources and investments going forward. So we're really moving to the opportunity to improve our system together. And so this is a really exciting time to be doing this work, and exciting in the sort of stressful way that we always experience, but also in a really hopeful way for moving forward. So Sarah, if you want to move to the next slide. And this is, again, just a reminder. I think, as I said, many of you know about this SUD waiver and have known about it for years, but some of you are new to the field or new to Oregon or new to this group, and I welcome you all. The reasons that we sought a Medicaid demonstration waiver specifically for SUD, a large portion of that is what is called the IMD exclusion, that again, I suspect many of you are familiar with, right? But IMD is a very stigma-filled and archaic term that stands for Institute of Mental Disease. And in practicality, what it means is that any program with more than 16 beds cannot receive Medicaid match, right? That's considered an Institute of Mental Disease. So if you are a substance use disorder residential provider, withdrawal management provider, and you've got 17 or more beds in your facility, we do not have the ability to do Medicaid match for that. So what Oregon has been doing for the past several years is just using general fund to backfill that. It's been hopefully pretty seamless to providers who have facilities with larger than 17 beds, but that means that there's been a chunk of money that has been used to cover those beds that couldn't be matched by Medicaid. This waiver allows us to waive that IMD exclusion, which means we can use Medicaid match for programs that are 17 beds or more. I think everyone here is probably aware that we have a serious lack of capacity for residential treatment for substance use disorder across the state. So the fact that we now can pay for services with Medicaid match in larger facilities gives us an opportunity to support the creation of some larger facilities and create some capacity throughout the state. And it also means that we have opportunities to invest those dollars in other ways for behavioral health, for substance use disorder, rather than just backfilling where we can now use Medicaid dollars. So the IMD exclusion was a huge part of the waiver. But we also got the opportunity to have some increased access to services that hadn't been paid for before, some housing supports, some employment supports. We asked for an expansion in peer-delivered services to be paid for before and after traditional enrollment and treatment, and CMS said that was a little too progressive for them right now, but they did leave the door open for us to continue to have that conversation as we move forward. The waiver will also give us access to specialty rates, an expanded continuum of care. We in Oregon have used the ASAM, American Society of Addiction Medication model for years and years, but this now puts it in explicitly in our Medicaid contract and has some fidelity requirements. So we'll be talking about those. But under this demonstration waiver, we in Oregon now have the opportunity to increase access for high quality, evidence-based opiate use disorder, substance use disorder treatment services across a continuum of care. So again, this is exciting work. I know many of us have been talking about this for years and years. So just pleased to have the opportunity to talk with you all today, share some more about it, answer some questions later. And I will turn my camera back over to Sarah so that she can move us on to our next presenter. Thank you all so much.
Thanks, Nicole. And actually, I am the next presenter, so here we are. Just wanted to talk a little bit more about the overview and the general requirements for the SUD waiver. Dana, if I miss anything, please pipe in and get me back on track. So the waiver itself was approved by CMS effective April 8th of last year through March 31st of 2026. So it's a 5-year approval. And there's many different projects and timelines associated with that, mostly along the lines of what Nicole was talking about. And many projects that have implementation timelines around January 2023, which is part of why we're meeting today to start talking more in depth about some of those activities. One being that there are new and higher reimbursement rates that are effective as of January 1st of this year. Due to some system and program delays that we've had, those claims will be retroactive, and we'll be able to talk about that a little bit more in our presentation later from our Medicaid side. Some of the goals of implementing all of these activities by January are around, expanding the continuum of care for people, initiation of services, treatment and recovery, especially once somebody has discharged from a residential program. We're looking to reduce the use of higher levels of care of emergency departments and inpatient hospital settings. Also looking to reduce readmissions to the same or higher level of care, especially if the readmission is preventable or medically inappropriate. And so a lot of the activities around supporting folks post-discharge from residential or inpatient are part of what we're working on. We're looking to increase the rates to identify, initiate, and engage in treatment for substance use disorders, and that's just a broad goal of the waiver. Part of the way we're doing that is by including housing support services in the treatment care plan, and there's some specific language around that as well. It's not as some folks have wondered if that is paying directly for housing, and under the waiver, that's not part of it, but we'll be able to talk about that a little bit more. And also a lot of work around the ASAM policy and implementation of that. And then, yeah, next slide, thank you. Some additional general requirements are around getting the average length of stay in residential treatment settings to 30 days or less. We're also looking for high quality and evidence-based OUD and SUD treatment services to, and that's for not only outpatient IOP, but also medication assisted treatment. We're looking to establish a utilization management approach so that people have access to services at the correct level of care, and that the interventions related to the treatment are appropriate for the diagnosis, so making sure those are paired. And that also includes having an independent process for reviewing an individual's placement in residential. We're also looking to address provider capacity at every level of care, and so that's medication assisted treatment as well. And there's assessment work that will be around the availability of providers to provide MAT across the state. We're also looking to address treatment of opioid abuse and looking at the prescribing guidelines, what other interventions can prevent prescription drug use, and we're looking to expand the coverage of and access to naloxone for overdose reversal, as well as to implement strategies to increase the utilization of the drug monitoring process in general. And then also looking to establish and implement policies to make sure that residential and inpatient treatment facilities can actually connect individuals with community-based care and those services following their stay in that level of care. All right, and I believe I will pass it to Delilah.
Yes, thank you. So we are working in regards to the enrollment process. We have updated the rates on our system as well. And so rates are ready to go. So currently we are working on a provider guide, and that would be to identify, specifying the community service, which talks about like the housing and employment support services. We are working to get that letter out soon, that communication. Provider enrollment is also currently working on updating the provider enrollment status on each specific provider ID to identify under what specialty they fall under, if they're going to be a IMD or non-IMD, what level of ASAM they have. That would give them a specific specialty type as well, and that would determine their reimbursement. Also, let's see, next slide, please, I believe. Sorry, I'm on the phones. I really can't see. I'm not at the computer.
Oh, that's okay, Delilah. I think I'm going to talk about IMD determinations on the next slide. This
Okay.
is Melissa.
Okay, just so also wanted to mention that we did go ahead and post it on our website, our memo that talks about what we're doing, what's going on, and also we updated a fact sheet that gives the providers all the current procedure codes that are new for the SUD program. It relates to the SUD waiver. It talks about the charges and a little bit about the specialty on there as well. Thank you.
Thanks, Delilah. So let's see, next slide. There we go. Okay, so our team is, the licensing and certification team is working on making designations for each of our licensed SUD residential treatment centers and detoxification centers or withdrawal management programs. And when that process is complete, each of the licenses for both SUD residential and withdrawal management across the state, whether you're IMD or not, whether you're Medicaid participating or not, all of the licenses will be updated to reflect these new data points of the IMD status, whether or not the program is approved to provide specialty services, and if the program is licensed as an SUD residential or withdrawal management program. Now, as far as specialty services, as for 2022, we've started out with 2 specialty services, one being culturally specific service and another being a parenting program. We're working on adding a couple or a few more specialty service types into the rules throughout this year, so they'll be available in 2023. And any program that doesn't have a specialty service acknowledged on their license in 2022 can apply for those specialty services to be added to their license for 2023. Although I suppose if you wanted to apply for the ones that are currently available, which are parenting and culturally specific, you could do that as well if it's not already added to your license automatically based on the work that you're currently doing. HSD has spent some time focusing on making sure that we fully understand what campuses are and common facilities and whatnot, so that we are making the most accurate determination of the IMG status as possible for each one of your programs across the state. And next year, we will be updating in January, we will be updating the licenses and certificates for all levels of ASAM to be included. So levels 0.5 through 3.7 for all types of SUD services. And this slide will give you a look at really the scope of this project. Because all of the ASAM levels of care affect so many different areas of work that we do, we're going to be updating those different various areas of rule. So we're looking at chapters 309, 415, and 410. Some things have already changed, especially in Division 172 of 410 around the specialty services. And most of this work is being done this year to add the ASAM into these various areas of rule in a more robust and clear fashion than they already are. Let's see, next slide. So here's some further requirements of the waiver. We saw some on an earlier slide when Sarah was speaking. These are the ones that we pulled out that are ASAM specific to give providers an idea of what the work we're going to be doing this year, both in HSD and with you as providers, to work together to get our continuum of care to a place where we're in compliance with CMS for this waiver. So Our continuum of care for the state needs to be based on ASAM, and in many ways it already is. Providers are going to assess treatment needs based on SUD specific, basically ASAM criteria. We're going to establish residential treatment provider qualifications. That includes staffing qualifications, the amount of staffing, hours in clinical care, things of that nature, as related to what's described in the ASAM text. We're going to also establish a review process that is consistent with ASAM, and that will be included in our regular review process that you already do with the members of our licensing and certification unit. And there's going to be a utilization management approach so basically what this says is part of our review, the licensing and certification review will also include a review of the placement decisions to ensure that the placement decisions are done to the standards of ASAM and in concert with ASAM standards. So let's see. Where's our next slide? So what does that mean? How is this impacting our work? So as we talked about, we're going to be revising the OARs. I think one of the bigger things for this year is that programs are going to apply to be approved to offer the different ASAM levels of care that they may or may not already be offering. And when we do that throughout this year, that's when we're going to update our certificates and licenses for next year. So we're going to work on this process this year, and it's going to be ready to be issued in the early part of January 2023. Our timeline right now is to have our applications to you, to the providers by June 30th, have the providers submit those applications to us, to HSD by September 30th, and then we will have the approvals done by the end of the year to be able to issue the new certificates and licenses at the beginning of January 2023. The other, I think, big lift that we're going to be talking about, and when I mean talking, our licensing and certification unit and other folks who work alongside us at HSD are planning on having webinars to work directly with the providers to help you with these changes. We're also working directly with ASAM here at the state, and they're helping provide us guidance on how to do things in a way that is to their standards. So some of the things that may or may not need to change in your program based on what you're already doing would be the assessment. ASAM is saying that the only acceptable assessment that demonstrates compliance with their standards is the one that they've issued that is free. It's their paper version. Service plans might need to be adjusted to accommodate ASAM criteria, and as well as maybe transfer summaries and possibly service notes as well. But those are things we're going to be digging into a little bit with you. Let's see, what's next? Okay, so certification and licensure, may have already touched on most of this already, but starting in January next year, our site reviews will include an ASAM component for each ASAM level of care that your program is approved to render. We've partnered with ASAM. We're going to be using their tools, and we may conduct some informal reviews across a sample of programs just to see how things are doing and provide technical assistance. We really want to support you in this process. Potential revision, we've kind of already talked about, a little few more things that might need to be revised to demonstrate compliance by 2023 would be program staff qualifications, policies and procedures, and protocols for each ASAM level of care. That include types of services, hours of clinical care, and credentials of staff to match each level of care. Let's see. Okay. And we got through this really fast. So I'm going to, Sissy Bollinger has agreed to be our questions moderator. And I haven't been watching the chat, but I see that there's some things in the chat. If you have questions, would you please put them in the chat, and we'd love to hear from you. Thank you.
Thank you, Melissa. So one of the first questions is, will the length of stay be longer than 30 days in parenting programs?
Dana, is this a question that you think you can speak to?
Sure. So CMS is wanting us to have an overall average, so it's not necessarily program specific or specialty specific. It's an evaluation of the overall system. And I think the last time we evaluated that, Oregon was actually on average under 30 days. So we'll continue to monitor that. We've continued to have discussions with CMS that our expectation is that the individual remains in residential treatment as long as it's clinically appropriate, that we're not a state that will be pushing for like a 28-day program or a 30-day program, that really this is an individualized treatment that is the length of stay is appropriate to each individual. The other aspect is to remember that some of the stays are longer because the first portion, it has to do with withdrawal management. And so really making sure that we're evaluating billing, and that billing is utilizing the appropriate codes. So if the individual is in withdrawal management, when they are admitted, that is what is being billed and being reimbursement for, so that we can really make sure that we're evaluating the day that residential services actually start. So I'll stop there, and hopefully that answered the question.
Yeah, thank you, Dana. A couple other clarifying questions have popped up related to that. Just clarifying that the length of stay will be no longer than 30 days, and will it apply to residential as well? And so what I heard Dana say, and Dana, correct me if I'm wrong, is that the average length of stay generally as an indicator will be 30 days. What we would expect, and what you all do, is that as long as it's clinically appropriate, that person would remain in care. And then we would look at the average based on the data, but that shouldn't drive the care. Is that accurate, Dana?
That's correct, yeah.
Thank you. So we'll, for residential programs that have both specialty programs like parenting and a non-specialty, how is OHA determining the status of those organizations?
Both statuses will be reflected on the license if it's all licensed for the same program.
Melissa, will they then get the rate, the reimbursement rate of the specialty program, the higher rate?
I will let Dana or Delilah speak to that. I'm not a rates person.
Sure. So I'll go ahead and jump in. So while we're sort of in this interim period of time, Delilah has been working with our Medicaid team to do some assumed status. So assumed IMDs, assumed non-IMDs, and then assumed specialty types, where if we have a company or a parent, we'll call them maybe a parent provider, where you have multiple programs, you're going to be entered into MMIS individually. Your programs will be entered individually as distinctly different customary charges. And I believe Delilah is working on a communication that will go out to each program, informing you of kind of what those assumptions were, and allowing you guys to get back to us and say, look, we don't agree with that, or can you help us understand additional details? So that work is underway. So right now it's all going to be assumed until Melissa's team is able to complete the official determination.
Yes, this is Delilah, and we are, like Dana said, working on it, and we're hoping to get those letters out by May 1st.
Melissa, did you have something to add to that?
I just wanted to say that what Dana's referring to is the assumed status. I think we've done a lot of work in conversation around this. I think most of them are accurate at this point. And there's the tricky ones are going to be the programs that have multiple licensed programs within the same facility, or what could possibly be considered a campus with multiple licensed programs located very close to each other in multiple facilities. And we just want to go through that process and make sure we got it right the first time. So if there are any changes, it's probably going to not be too many, and we should have those done fairly quickly. So hopefully by May 1st, they're all going out accurate the first time. I also wanted to mention that when Delilah said she was referring to a few rate sheets and whatnot that were sent out, those were attached to the Zoom meeting early this morning. So you should have those available to you.
And just to clarify regarding process, at the end of December, we pulled all of the programs that we believed met criteria for IMD and provided that to our Medicaid partners so that we can start working on the system work for payments. And what Melissa is saying is that we're going to now confirm those based on our clarified definition that we've been working through related to the CFRs and campus and things that Melissa said. So just wanted to explain a little bit about the process. And so that's where we're at now, and we'll just verify that and then get those updated licenses out to you all. So here is a Medicaid question. Customary charge was clarified for residential programs. However, H2036 did not receive clarification. Is there a reason for this? And my apologies, I don't know what that code is. So Delilah, if that makes sense to you and if it fits in this conversation, we can do our best to address it. Otherwise, if we're not able to address any of the questions, we will circle back with you all.
Dana, can somebody pull up what the description of that code is, please?
Sure. So, so this is the day treatment program where there has been a customary charge assigned to that level of care. So that's ASAM level 2.5. There has been some clarification that was part of the fact sheet. So maybe Jonathan, if you want to send us an email about what hasn't been answered in the fact sheet, that would be great. Part of that is for day treatment programs that have housing support services attached to them. So we have a handful across the state. That rate would predominantly apply to those particular programs, and that they would receive that daily customary charge from 2.5 as they're transitioning to lower levels of care, such as intensive outpatient treatment. That rate would still apply as well. So there is probably additional details that we could provide or need to provide. So if you have specific questions, maybe we can answer those via an email, or we can start up an advisory group specifically on this topic as well.
Thank you, Dana. So I can answer this one. For agencies who have COAs, certificates of approval or licensing reviews coming due in the fall, will those reviews include the new standard? So any reviews that we do, we would take the rules that pertain to that time period that we are reviewing. So no. However, we would love to have the conversations and engage in any kind of technical assistance that we can provide to help move things forward and support you in moving in this direction. Anybody on the licensing team have anything to add to that? Okay. Just a comment, and then we'll get to the next question. It would be great to see integrated co-occurring dual diagnosis outpatient and res programs as a quote specialty unquote and reimbursed accordingly until it becomes the standard rather than a specialty, as it should. So let's see, let's get to our next question. Another comment, and just to share the comments that folks are having, would love to see a biopsych assessment for SUD and mental health that complies with ASAM that can be uploaded into the EMR. And a request to say more about how you are imagining the quote independent utilization management unquote process. Will this be a model similar to what you use in mental health programming? I'm not sure if folks understand what is intended there or if we need more clarification on that question.
I think I understand what Allison is asking. And I can, just speaking for myself, I don't know what the model is that's used in mental health. But we can certainly consult with internally with our peers around that. I'm not interested in inventing any new wheels. So basically the utilization management process, we'll see what ASAM has first of all for their tools. If they have a tool that we can use, then we're certainly going to adopt that. And possibly the mental health tool that is used by HSD already can influence our process. So that's something that we're going to be figuring out as we go this year. It won't start until next year, so we have some time to build that framework and find those tools.
Yeah, and just to build on to that, so the licensing, certification, and technical assistance team will be conducting the ASAM evaluation assessments versus on the mental health side, those independent reviews of the utilization anyway are done by Comagine. So if that helps at all, that is the response to that. Is there, Allison, did we get to your, did we
Yeah,
give you enough information? Okay.
if you don't mind, I think you started to get there, and please reinvent that wheel. I appreciate Melissa's statement about wanting to learn from what may be happening in the mental health residential, and that's not working. So please don't do that.
Noted. Thank you.
Good clarification. Thank you.
So, Melissa, can you talk to, will everyone need to use the free ASAM assessment?
Yes. So I've been consulting directly with ASAM. That's part of my role. And I did a lot of vetting around this question. And the answer is clear that if the state wants to be in compliance with CMS, then the only tool that we have available to us is the ASAM free assessment tool that they published.
Okay.
I'm going to, based on the comments, especially around co-occurring and having that one biopsychosocial that's compliant with ASAM, those are great comments. Those are things that I'm going to look into to see how we can simplify things and streamline things and use that ASAM tool, and maybe we build into it here and there just to have an all-in-one. But those are also things that, you know, we can work on together over this year. And I'll be looking forward to any input that the community has for us.
Thanks, Melissa. Kind of related to that, will agencies be required to have each of their program levels of care go through an ASAM certification?
Yes. So if you are if your program is outpatient, it's certified as outpatient, all the different levels of ASAM that your program bills or renders will have to be certified independently. So 0.5, 1.0, 2.1, etc. The same for residential. If you're offering multiple levels of care, ASAM levels of care within the residential 3.0 level, or detoxification, the 2 levels that we have available. And then once that is done through an application process, it will be showing on the license or the certificate in 2023.
Okay. And we have a couple hands up. Erica, Heather, I'm not sure which of you was first, so if one of you would like to jump in.
I'll let Erica go first. This is Heather.
Thank you.
So a couple things for clarification. So many of us have integrated or ASAM assessments built into our electronic health record. So I guess I'm asking for clarification. Is that going to be sufficient, or do we actually need to use something provided and, as the official ASAM assessment? Are we gonna have to create something new within our EHR, or if we have an ASAM assessment, is that sufficient? So that's my first question. My second is for clarification is, I understand we will have to apply through OHA for the different levels of care. Are we going to have to apply and go through a certification process with ASAM directly for each and get certified through ASAM for each of our levels of care? Which is a whole undertaking. So that's why I'm asking.
Right. No. No. You do not have to be approved through ASAM itself. ASAM doesn't actually do those approvals themselves. CARF is an independent contractor that does that. They've created their own standards, and ASAM, they have some sort of agreement that allows them to do that. But no, we are not moving in that direction as a state.
Thank you for clarifying that.
Yeah. We looked into it as an option, and I'm sure it would be a lovely standard. We did a lot of considering, and a big part of our decision came down to costs that would be passed on to the providers, that we didn't want to do that to the providers. So we're building it ourselves, and we're relying on ASAM's tools, that they're proprietary tools that they're allowing us to use. So we cannot share those tools with anyone outside of our unit, really. They're very, we have to hold them very close. So in the past, I know providers have always asked us, can you share your review tools? We want to see them, and we've always shared them, because basically they're just really copies of the rule. But the review tools that are going to be ASAM specific, we're not going to be able to share those. But just know that they're basically kind of what we were doing. It's like you take the rule and you turn it into a tool, or you take the ASAM text, you turn it into a tool. So there shouldn't be any surprises. We just can't share the actual tool with the community.
Yeah, I wanted to share too that, so one of the decisions also to do it in-house and work with you all is that, especially in this challenging time of staffing shortages, we're looking at reducing administrative burden and not increasing that. So we're going to do all we can to create a process where we're taking the information that we work with you on, and so that we can do our ASAM reviews, our site review reviews. We're going to do our best, and we'll get your input on how to make that as seamless as possible.
This is Heather. I just wanted to follow up on a quick question with ASAM. Thank you guys for working so closely with ASAM, and that's such an exciting project that ASAM is collaborating with CARF and that they launched that. accreditation opportunity for providers nationwide to be ASAM and CARF accredited, though I do believe that you don't have to bundle them. You can do them separately, is my understanding from the ASAM folks. But my other question was, I know that Health IT is looking at lifting IT solutions for the behavioral health system, both mental health and SUD across the state of Oregon. And I know many providers have looked at the ASAM Continuum IT solution, which includes both referral, screening, and assessment capacity, and follows consumers over time, and can be used by folks in various settings, whether that's an emergency room, clinical site, outreach, and then it reduces repetition for the consumer because the ROIs are contained within. It really would be phenomenal if part of an investment through the IT solution. I don't know how closely you guys are working with them in that unit, but if Continuum would be part of that, because it really would increase consistency and the utilization of the ASAM tool across the whole continuum of care. So So anyway, it's just a suggestion. I know it's something that folks have looked at. It's really not financially, as you mentioned, financially sustainable for individual agencies, nor would it really make that big of an impact for individual agencies to participate at it. But at the state level, since there is some investments at that level, it really could make, at least the little I know about it, it seems like it could really make a difference and be pretty impactful for the system of care.
Thank you, Heather. Any thoughts or responses to Heather's comments? So building on the ASAM questions and clarifications, will providers be asked to go back to a paper assessment because that is the only version available by ASAM?
I'm sorry, can you repeat the question?
Sure. Are providers going to be asked to go back to a paper assessment because that's the only version available by ASAM?
Yeah, this is and I know there's several other questions like this in the chat. I'm trying to keep my eye on it. And Erica, that was your first question, and I didn't really speak to that. So what I know at this moment is that the one assessment that is fully compliant with ASAM, that the only one that ASAM will acknowledge as compliant, is their own paper assessment. And I also know that CMS has required us to be compliant with ASAM. So that's where the rubber's meeting the road. And if there is room to assist providers in continuing to use their own tools that have already been built, but adjusting them to meet, I don't know. I just don't know. It's something that I'm happy to look into as we go through these things, because I understand that there's a huge lift and a cost, and there's processes that need to be put in place, and it can be complex. So it's certainly something that we'll look into more. But I do feel like I hit a wall with that answer with ASAM. And so I'm still okay with like exploring, right? I just don't know if I'm going to get anywhere. So I just want to be clear about that. But I will do whatever I can, because I understand, you know, I used to be a provider myself. I know how hard it can be. So anything that we can do to reduce the impact on the providers, we're certainly going to look at for you.
Yeah, and want to let you know that we are hearing you, that a paper assessment does not cover all other, you know, community partner stakeholder concerns. So we're hearing you on that, and we'll take a look at it, and there will be more discussions following this one. Melissa, is there a cost for the ASAM certification? And if so, is it a one-time charge?
There's no cost because we are doing it as a state. So by not going through CARF, we remove that cost.
Thank you.
And I just want to say that it's called the paper version. I see in the chat, Emily said there's a free fillable electronic version. That's probably true. They call it the paper version because they've distributed it like via PDF, I think. So again, I have lots of research to do. And this is definitely one of the big areas where I'm going to be learning more and sharing more with the providers as soon as I know.
And there is a question in here, so we'll need to do 2 assessments at least. And I know there's a lot of conversations swirling around the different assessments and things like that. Melissa, I don't know if you have anything to share on this yet, or if we need to take this back and talk more as a team.
I'm going to make an assumption that the 2 assessments, when that statement's being made, it's probably because there's co-occurring disorders program, and there's a mental health component that's not thoroughly, it's not completed when you just do an ASAM assessment. There's more that's needed. Yes, these are things that we need to have more discussions about internally and with the community, everyone here in this room, or some folks here in this room, whoever's wanting to participate in that communication and that conversation. And again, I want to streamline this as much as possible for you. I think everybody at the state wants to streamline and have this be the least impactful as possible. So this is a big part of our work that we're undertaking. And as a, there's a lot of things going on right now, and this is one of them. So if you have ideas, I'm happy to talk to you or hear them. However you want to communicate with me is fine.
Yeah, it looks also like there's a free assessment for adults, but not necessarily one for adolescents. Is that accurate? And will there be one coming, or how does that work?
That's a good question. I will write that down and I will look into that. I would imagine that the adolescent version is there, but I don't know.
Okay. Is it possible, we may not know this yet, but can providers recreate the exact assessment in their EMR rather than use the paper and have that be considered compliant?
I would assume so.
Yeah. Let us clarify, because we don't want to steer you wrong, and we know EMR changes are expensive. So we're going to take all of these back and do a deeper dive, but just wanting to be responsive now in the moment as well with what we do know. So we will look more at that. There's also did you look at the continuum software? And I would say probably not. We have not looked at software related to this at this point that I'm aware of.
I would agree with that.
So there's, will the assessment meet CARF standards? I don't even know that we're addressing that because we're not trying to comply with CARF, but Melissa, do you have any thoughts on that?
Well, that's true. We as a state, we don't need to comply with CARF, so it's not something that we take into consideration. My understanding is that the assessment that ASAM has distributed, that they call the free paper assessment, is the same one that is required by CARF if you're CARF certified for ASAM levels of care. But again, I don't need to know that, so that's a little unclear to me.
Okay. So will the ASAM requirements extend to private agencies?
Yeah.
I would imagine if they're licensed by us, that would be the case. Melissa, do you have other thoughts?
Sorry, would you restate the question?
Oh, absolutely. Are ASAM requirements extended to private agencies?
Yes, I'm sorry. That is something I wanted to speak to earlier in the slides. Good clarification. Yeah, so the CMS waiver requires that if a program is certified or licensed for substance abuse treatment, all programs, whether they accept public dollars or not, are going to be a part of this process and held to the same ASAM and OAR standards. It's all going to be an OAR, so it's going to be applied across the board.
Thank you. I wanted to go back. David, did you have a comment you wanted to, there was someone talked about 2 assessments, and we talked a little bit about if there's behavioral health as well as SUD. David, can you speak to the co-occurring disorder work that we're working on right now in relation to this?
I guess, yeah, briefly. I mean, I think some folks on this call are aware of the initiative or the program development that we're doing out of House Bill 2086 from the 2021 session around standing up an integrated co-occurring disorders program through 309-019-145. So we'll be revising rule in that area. And also we have some work groups, advisory groups already forming, including internal groups. And also some of you all are involved with our provider participation groups around standing up this work. So I just wanted to thank you, Sissy. I threw you a private comment, said something about that. So I think there was a question earlier in the chat that you read out about doing integrated co-occurring disorders work and having an integrated payment model and such. So not to overwhelm with a side project and get into the weeds on that, but I just wanted to make sure that folks in this call also knew that this is something that we're working on, and we'll need to connect with the ASAM requirements that are moving forward through the SUD waiver. Is there something I missed there, Sissy?
No, thank you so much. Appreciate that.
Yeah, thanks.
When will folks need to start using the ASAM version for the assessment?
So we anticipate that the rules will be in effect in November or December of this year, but by January 1st at the latest.
So we're going to do some engagement around the rules process, make sure we have plenty of diverse voices at the table representing of the community. So we'll do that engagement, as well as the official rules advisory committee, public hearing. So we've allocated time for all of that. So you will be hearing more about that and have a chance to weigh in on prior to the rule development, and then through the rules advisory committee and the public hearing in more formal channels as well. Let's see. So there is a question, and I don't think we have an answer to that, but it's a good question. If there's a cost associated with creating or altering the ASAM assessment within the electronic health record, will OHA provide agencies financial support? And that's definitely something that we can take back and talk more about. Appreciate that question. Thank you. Let's see. And feel free, and if you are raising your hand and I don't see you, please just shout out and get our attention. That's okay too.
I wanted to ask a question about the peer support.
Sure.
The code H0038 has not been getting paid by OMAP, and they keep telling us that it's a problem within the system. Has that been repaired or not? Because we're several months behind on being paid for that.
Yeah, I don't know if we have anybody on the call that can address.
Hi.
Is there somebody that can?
Hi, Cece. This is Delilah. Yes, Medicaid met with our system division program on March 14, and we figured it out and fixed the issue. So if you're still not getting if you're still getting claims denied, please go ahead and email them to the email I will post on the chat, which is our Medicaid email that will send a ticket to us for us to individually look at your specific claims and figure out if there's anything else that we looked at the system and we figure this is what it needs to get done in order to continue improving those claims. But if we miss something, please go ahead and send us an email with your claim denials. Thank you.
Yeah, thank you for that question. And Delilah, thank you so much for that clarification. Hopefully folks have been paid, but it sounds like maybe there's still a bit of an issue. So yeah, please get that to the Medicaid programs email address that's in the chat currently. I believe I've addressed all that are in the chat, but if I've missed something, please feel free to speak up. And or any other questions or comments. I know that we'll be addressing in next steps some of the things that we're going to do to further engage with you all. Well, thank you so much for these great questions. And again, we will be looking at these more in depth. For any of the comments that we didn't share, we'll be taking a look at those as well. And really appreciate you all so much for being here and for your wisdom and working on this together with us. So Melissa, turn it over to you for next steps.
Hello again. Sorry, I went off camera. Let's start that again. So next steps. We welcome your continued input. The SUD 1115 waiver has its own website, which you can see at the bottom line of this slide. On that, and I think it's like the kind of top right area of that page, there is a link to email our team if you have further questions or comments that you'd like to share with us. We are planning several follow-up meetings that are more topic specific, and your comments and questions can help us decide and formulate what kinds of topic specific meetings will be most important. And we'll be also the Licensing Certification and Technical Assistance Unit will be providing technical assistance meetings throughout this year and the next year or even more to help programs lift this off the ground and continue to make the changes that are needed and support them in that work. So we want to work with you and collaborate with you on this project. We want it to succeed. We want you to succeed, and we want to be a part of making this great. So Sarah, would you like to add anything? So thank you all.
Thanks, Melissa.
Just real quick, so in the chat, a copy of the recording, we will be putting a copy of the recording on the website to make sure that you can review it or pass it on. Go ahead, Sarah. So thank you.
Oh, thank you. I think the only thing I wanted to point out is that Delilah did put the email address that she was referring to in the chat regarding the claims. That is a different email address than this SUD waiver inbox that's posted on the slide that you're seeing. So I just wanted to point out that there are two possible points of contact there, and the one that she had posted is specific to the claims issues. But that's it.
So that's what we have for you, unless anybody has any parting words of wisdom as we move forward in this work.
There are a few questions about how to get a copy of the recording once the meeting is over.
Oh, we will be posting that to the website.
And the website address is listed at the bottom of the screen on this slide. I don't know if I can paste that into the chat. I'm going to paste that into the chat if it makes it easier for some folks.
Thank you. Well, that is our show for today. Thank you again for coming. Really appreciate it.
Thanks, everyone.
Thanks so much, everyone. And we do see all the questions about ASAM and assessment. We will certainly be digging into that. We're not ignoring you. Thanks so much for being here.
Thank you.
Thank you.